Hi, I'm Dr. Merran Cooper and I'm here because I want to tell you some stories. I am a normal person, hence no stethoscope, and I want to speak to you as normal people. The three stories I want to tell you happened to me all on the one shift, which tells you how frequent and how common these sorts of stories are. The first story I want to tell you was about a lady who was 99. I won't tell you her name. She had white hair, she was very tiny, and she was curled up on the bed. She was what we call non-verbal dementia. And she'd been brought in from a residential aged care facility to the hospital because she had a leg ulcer that had become cellulitis, and the infection had turned into the bone. So she would have had a fair bit of pain. And she was getting antibiotics every day. So we were putting cannulas in her elbows every day, and they were tissue, and we had to change them nearly every shift. And she had very low electrolytes, so she had low levels of potassium. So we had to give her potassium IV as well. After around about a week of this, she was spitting out the tablets, she was pulling out the cannulas, she was pushing us away every time we tried to put a new one in. And so I rang the treating doctor. It was quite late. And I said, I'm really uncomfortable putting more cannulas in this lady. I think that she's trying to tell us something. And I said, I think she's trying to die. And we're just maybe even doing more harm than good. And the doctor said, but Merran, if we don't give her more potassium, she will develop a life-threatening low potassium level. And I went, yes, she will. And the doctor said, well, don't give her any more cannulas overnight tonight. Tomorrow, in the morning, we'll take her to theatre and we will put in a line into the vein higher up in her arm, deeper, so we can give her the potassium and the antibiotics through that. Now, this lady had antibiotic-resistant infection. She was having quite heavy-duty antibiotics. And to tell you the honest truth, I was going off shift then. It was the end of my 12-hour shift and I was pretty tired. And going home, and I was going on leave the very next day, so I wouldn't even know what was going to happen to that lady. And this is an ongoing problem in the hospitals. We do shift work. So even if you are somebody who tries to put your hand up and tries to say, please can we stop doing this to this person, you're gone the next day and there's somebody else who comes on with a different attitude. Some people would say, why don't you ask the lady's family what they want? But you know what? She had an 81-year-old son who also had non-verbal dementia. What do you do? The next story I want to tell you happened on the same day, earlier in the afternoon. And I was rounding with a respiratory physician. It was the weekend, so he had a little bit more time than usual. He was dressed casually in just like an open neck shirt and pants. He was kind of like a cool dad or even a cool young grandfather, a really nice guy. And we went around to see the patients together. And he said to me, Merran, our hospitals are full of old people with pneumonia. And he was shrugging his shoulders, saying, I can fix them all. But is that the right thing to do? You know what? When somebody has advanced dementia, what they often do is forget to swallow. The food stays in the front of your mouth and you forget to roll it to the back of your mouth, and then you fall asleep. And then the food goes down into your lung and you develop an aspiration pneumonia. It's really common in people who can't swallow. Left alone, at the end of their life, when the rest of their body is already weak, they would likely fall asleep and die in their sleep. But we save them. And you have to wonder why. Is it because of fear? Is it because of fear of death? Is it because of fear of being sued? Is it because fear of sounding callous? Is it because the family are just too scared to bring up the topic, so we just by default let all treatment happen? Why do we do this? Why do we not speak up? Think about things ahead of time. Say what we do and what we don't want. Some of the reason is because people out there in normal land are not informed about what goes on in hospital land, and that's why I'm telling you these stories. So, the respiratory physician and I visited a lady who had advanced dementia, who had forgotten to swallow, and who had developed an aspiration pneumonia. She'd been with severe dementia for quite a few years from a residential aged care facility. When we went to see her, her son was visiting. He was around 61 years old, and he was very intelligent and very confident. So the respiratory physician said to the son, "Sir, your mother has this pneumonia, and in order to prevent it getting worse, we've put a nasogastric tube down her so that we feed her through the tube. This is common practice." But she pulled the tube out. And so the doctors put in another tube, and she pulled that one out. So the respiratory physician said to the son, "Sir, would it be okay with you if we used a small amount of restraint to hold your mother's hands still so she didn't pull the next tube out?" And the son said, "No, that would not be my preference. I would like you to sit her up and try her to have little sips and little swallows of food and see how she goes. And if she develops a pneumonia, that's okay." But he did not want her to have another tube. He did not want her to be restrained. And had he not been there visiting, or had he not been equipped to answer a question like that on the spot, a younger doctor, perhaps, would have retubed and restrained, because that's what the guidelines say. Without direction from the family, it's very hard not to treat against the guidelines. So I'm begging you, as loved ones and as patients yourselves, make it very, very clear to your treating doctors what you want. Discuss with them. They want to hear you. So many doctors are just going, "I can't do this. What's going on? We're over-treating," but they haven't got the permission from the family to treat wisely. The third story I want to tell you happened earlier on the same day. There was a man from, I don't know where he's from, overseas. He was non-English speaking, and this is a common problem. Patients don't speak the same language as the doctors or the nurses, or they're non-verbal. His two daughters were visiting from overseas. They said to me, "Merran, he's asleep all the time. We don't even get to say hello to him. What's going on?" And it turned out that he was being woken every single night by nurses doing OBS, doing thermometer, blood pressure, pulse rate, checking his respiratory rate to see how he was going. And so he wasn't getting a good night's sleep. The family knew, and he knew, he only had a couple of weeks to live. And he was quite comfortable in the hospital. He had a great room, and his family were around him. But this was the problem. And I said, "But haven't you discussed that he's for palliation, he's palliative care, and he's not supposed to have all the OBS if he's for palliation?" They said, "Yeah, we think so. We phoned a doctor and they were going to write it down somewhere." And this is the problem. Hospitals are a place where verbal communication goes to die. You need to talk the language of the hospitals, and that is digital, electronic. It has to be in the patient's notes where everybody can see it, and that is electronic, which is why I've created Touchstone Life Care. It's an electronic document of your wishes that can be on your phone, emailed to your GP, emailed to the hospital, hopefully eventually in the hospital records, but everybody can have access to it at any instant. So in this person's case, we went looking for the piece of paper that we think some doctor had written somewhere, we didn't know where. Deep down in the bottom of a folder, I found an illegible piece of paper that said, "Family want comfort care." And these are the euphemisms that we use in hospitals. So in this gentleman's case, we wrote all over his notes, please do not wake at night. Please do not do OBS at night. The family have requested it. And I'm hoping that he got a good couple of nights sleep and that he was able to spend some good quality time with his two daughters who were visiting just for 2 weeks. There's a fourth story from the same day of a lady who was from Japan, and she wanted to go home to Japan before she died to see her family. And nobody said to her, you know what, you might not make that. Because we were trying to be positive and not use the D word and not go there. She knew she was dying, and she was optimistic to the end. But hospitals are not a place where we come up with creative ideas. And we could have said to her, how about we set up a Zoom interview here in your hospital bed for you to Zoom your family in Japan. They can all come on board and you can all have a chat, as well as trying to get back to Japan. But it's not the place for clever ideas in hospital. We're all too busy. We had about 5 minutes with that lady from Japan. How are you going? Are you okay? Are you in pain? What do we need to do for you? And she said, no, I'm good, doctor, thanks, I'm fine. All your OBS look good. Okay, next patient. We didn't sit down and say, what are your wishes? How can we make those happen? How can we come up with creative solutions? So these are things for families to talk about at home. Put in writing. You don't get a chance to talk to your doctors very often. It is very hard in a hospital. But if you can make your wishes very clear, hang out with your loved one in the hospital for a while you're visiting, and give or show an electronic copy, a digital copy that is validation that you've had these discussions. That's what the hospital staff will believe. Some kind of validation that you've had deep, meaningful discussions with your family. You know what? Talking about death is like talking about sex. You start with little bits. You don't go right into the whole sex education with your children all in one go. And we don't go right into the whole death talk with our loved ones all in one go. You start small. Talk about the easy things. Hey, you know what? When I die, this is what I'd like. And that's enough. And then the next conversation maybe go a little bit more. But we're only human beings. None of us like having these difficult conversations. They take practice and little bits at a time. Please understand, doctors are human beings under a lot of stress. So are loved ones in hospital. The power structures in hospital, whether we like it or not, are different to at home, and it is very hard to speak up to a doctor in a rushed time. So do it at home. Take time and say what you really want.